All right, so Kevin asked me to talk to you guys about a number of topics today. One is no contact, refusals, ketamine and meds, second signature on refusals, and then some COVID stuff and some COVID questions if you guys have a chance or need anything answered there. So as for the no contact refusals, kind of like what we do in the emergency room is we have to have what's called a medical screening exam from a EMTALA standpoint. Granted, you guys are not overseen by the EMTALA rules, which is you have to do a medical screening exam before discharging a patient. So I can send someone away from my ER by doing a thorough screening and sending them home from triage. I don't have to bring them back, I don't have to see them, but I have to look at them. That kind of applies with us because from a medical legal standpoint, if we get a refusal and just walk away without having that initial contact with that patient, that puts us at high liability. So we need to have, even in a refusal, a interaction that documents things from a legal standpoint, that we were there, that they were not dying, that we had a signature from someone in their party that says that they're responsible for that patient or that patient's responsible for themselves. And then you can go back to your normal activities. But you have to make a contact. We just can't have, and we came into problems with that at other, had this question come up like with buses, like someone gets in a bus crash and you've got 20 people on the bus. What do? My answer was, and I don't know what your feeling on that is take all the names, take all the refusals, write all the reports, because we were called to that scene. We just can't walk away and say, we're not looking at these people. I think we have an obligation, but do you have?
Well, I know what Chief's take on that is that once we make contact, we are initiating a report on them. Is that some kind of HIPAA violation? We're creating a report?
No, I think we should create a report. And even though it's sometimes tedious to create a report of 6 people in a vehicle, I still think we have to make that contact so that it protects us. Because if someone within that vehicle said, hey, they didn't touch me and my chest is injured, we're liable.
Right, so what about the situation where you run into, where you get called for a car wreck, nobody's hurt, you walk up to the car and it's like, I didn't call 911 and I don't want you here. You just document, are you good with us just documenting the fact that they want no part of us?
Yeah, and if you can get 4 occupants in the vehicle, all 4 said that they did not need our services, if you can get a name, obviously that fully substantiates that, and then have 2 people in the crew, supervisor and the person taking the report, sign it. And then that just protects us from a legal standpoint that says that we tried to make that contact with Susie, Bob, Jim, and John in the car. All 4 refused. You saw it, we write it down. So if anybody ever comes back and says, we weren't seen, we weren't questioned, we have that documentation to support and protect us from a legal standpoint. Does that seem pretty consistent with Steve's views?
Yeah, his concern is that we show up and now we've created a report and they're going to get a bill for a refusal for $50 from the billing company.
Oh, they do give them?
Yes. So, where do we try to resolve that to the billing company? And
yeah, I would think a no contact shouldn't generate a bill. Well, let me rephrase that. If we're called out to a house and we do stuff, that should, with a no contact refusal, create a bill.
Correct.
Because we rendered our services and evaluated a person. But I think in the standpoint like a car accident, a minor fender bender, you go to the scene and there's 4 people in the car saying, no, I don't think they each need to be billed.
Then we resolve that.
Right.
And that's what we see more of is car crashes. Somebody drives by, sees it, they call it in, we respond.
Right.
And we walk up. We just had one on Snyder Road. The kid in the car was like, I don't need you guys.
Right. And I think a general report that you would start and write for any sort of a run like that, responded to, call.
So they just do NPC, but there's no information, there's no information that you want to give us.
Right, and that's fine. You could just document that refusal and sign, have 2 people sign.
Yeah, I'll clarify that with the billing company.
Yeah.
Figure it out.
Yeah, I think that's the best approach. It keeps us safe,
Right.
We saw that there were 4 people, all 4 refused, doubly noted, signed, and no one can come back to us and say, well, you didn't look at my kid for that.
Right.
You can also do that with the EPC, or the EPCR report the market, not the.
Yeah. But I would definitely bill, like I said, if you go to like an overdose,
Right.
and the person refuses, they're awake and alert and have the capacity to refuse,
I
I think that needs to be billed. What was the ketamine question? Are we good with the refusal question? And that kind of covered the 2 signature thing. I think it should be the person writing the report and whoever is the oversight on that shift.
Yeah. Pretty clear. The ketamine was for, if I'm not correct, if I'm wrong, guys, is when we have an issue where the medical direction on the phone says give them so much ketamine because they're being
Like a behavior patient?
Yes.
Yeah.
He uses chemical restraint protocol, only uses pain
What's the current Southwest? What's our protocol on
control.
ketamine?
Only pain control for opiate, suspected opiate users or people that are on high-dose opiates for chronic cancer patients or something like that.
Oh, and it's for pain control?
Yes,
Blood
so
pressure.
pain control. We
They don't have
it in our
a
protocol
psych
or-
part of it?
No,
Oh, they do.
not in this one. So when we were calling for psych, they're telling us to use ketamine, and it's not in our protocol, but we're giving up direction to use ketamine.
Is it an addendum? Can someone search up the Southwest and see, well, not right now, but just ask someone to search up if there is an addendum protocol for that? And we can sign that, I don't mind. I love ketamine. But yeah, no, I mean, we just have to do a training on it, and I think we need to get it in our protocol. So if we're seeing that as a more common ask by the online medical control,
They're asking for that as a percent.
yeah, it works better. So yeah, let's just write a protocol addendum. We can send it in this date. It's easy. Am I not on? It's supposed to be back.
It doesn't matter. As long as you can hear it, hopefully.
So yeah, do you want to task somebody with that?
Yeah, we got it.
Yeah, it's easy.
The new EMS chief, if you're not aware, is the cheetah is on it.
So questions on ketamine? Anything? All right, COVID questions. My question, are we taking temperatures?
Yes,
People come in every day,
yes.
Twice a day.
twice a day, mid-shift. That's good. And then we're not working if we're febrile and we're going home. And then how are we working patients who we contact with and potentially have it?
Goggles, N95 gowns, mask on them.
The rest of the calls is glass, or eye shield, gloves, mask. And then if it's possible, they're doing N95, putting a mask on the patient as well.
Yeah, I would always mask patients right away. And are we doing a limited number of provider contact? That's the next question, because from our standpoint in the ER, that's what we're doing. We're one nurse, one doc going in, seeing people. So we're gonna do a limited assessment with one individual.
How do you feel about N95 on every respiratory run, chest pain? And can we do surgical masks?
If we have the equipment, wear the max because it is airborne. And it's there. If they're in their house coughing, it's in there. So if you wear a little surgical mask, it's gonna come in. So now what I'm doing in the ER is wearing my N95 and then putting a surgical mask over top it, and then disposing of my surgical and recycling my N95 throughout the day, and then we're cleaning them at the end of the shift. So that may be something to kind of protect your N95, and I don't know if we're gonna start using the cleaning to process them.
We're working on a thing right now with Bethesda, and then to get a system going, or we can do it from Claremont, Mercy.
Yeah.
We got that in
But yeah, I would on everybody. I do on everybody until I'm sure. And even on the ones that, honestly, I'm walking in with a mask on most people. because there's, you hear about all these people with like back strains and broken arms and things like that who have COVID. So I would maximize your PPE at all times. Always wear gloves, always wear a surgical until you're absolutely certain. And now with these bad respiratories, are we wearing our respirators or anything in the truck on the way to places, or?
Like our SCBA pack?
I don't know how far we go when it hits. I mean, if this gets like New York is getting.
That's what plan B if we run out.
Yeah.
Start wearing the SCBA.
And those high-risk ones, like if they're febrile and fully sick and respiratory, that might be a good time to just wear those.
Now, if we were to start in like New York, would you want us to start refusing to take people with like stupid, like?
So yeah, it sort of all depends on the volume, and that came out from the protocol committee about how we're going to down-regulate transports as the up-regulation requests happen. And we've got to kind of do that on a case-by-case basis, obviously, but if it gets to the point where we've got, how many engines running at once? Two. If we get 4 calls, we're going to have to say no to certain people. And I think, although it dumps us into a bunch of liability, it's to the point when it comes to where, like we're in New York, where there's runs and runs and runs, and we just don't have the capacity, we've got to say no, we can't take the time. So we're going to have to start doing a better triage and a better assessment and doing that full medical screening and exam to at least give us some protection from liability against what goes on, but say, look, the situation is what it is, and we've got to do what's best for our community. And Steve had sent me something about the testing that's coming out, the antibody testing. I think it'd be a good idea to carry it, but that's just gonna, if the public finds out we're carrying it, it's gonna increase the calls. Right. And the Fire Chiefs Association want to talk about setting up, once that testing comes out, sites for testing in the county, townships.
Right.
The firehouse have you seen those booths in Asia where they have, they're in a box, and they have the gloves like for incubators, and they're doing it so they don't have to switch PPE every time.
But the residents next door have a wire down in the yard that's pulling other wires and working it.
That may be what it's coming to.
Daryl wanted me to ask you, what is your opinion of the hydroxychloroquine and the erythromycin combination? Might be something that we would consider down the road.
I think that's going to end up being more for the sick and for the
Right.
people that are hospitalized in the ICU and things like that versus something we would carry specifically.
Right.
Just because of the side effects of the hydroxychloroquine, it's better to be. So I think it would be overused if it was a more available product.
Right.
So as a lot of people say, it's just as bad as the flu. It's worse than the flu, obviously. For us individually, we probably would get something like the flu like illness. Me and you might not. You might get sick.
Right.
He's getting old. He might get sick. But so if you start throwing hydroxychloroquine to everybody and get one side effects or 2 run out,
Right.
those are the 2 points that it becomes a bottleneck situation. We're not going to have enough. So I'd probably say no, unless it becomes like a stage thing, but I don't think it will. I don't think they've got the capacity to deliver that much drug.
Got it.
How much longer do you think this pandemic's gonna last?
I think once it gets hot, I think June, gets up persistently in the 80s. I think it's going to drop down, but I can't. I hope. But then you see it in the southern hemisphere, so it's warm down there, or it was, when we were getting started. So I don't know. Questions?
26.2
Any other questions?
Doesn't have to be COVID, can be anything.
Let's wait on Cody to text me back. Ask you any questions. He asked me the other day.
Right.
trying to fix that much more.
Have you guys seen a decrease in cases? I mean, just overall cases in the ER, or is it?
We have about a 40% reduction in volume. In my standalones, I'm seeing 10 people, maybe, for a 12-hour shift. Yeah.
Yeah, the guys are coming back from Bethesda saying it's a ghost town over there.
Yeah, I mean, there's, in Kettering, I mean, huge trauma center, you're walking through, it's just like empty rooms, it's spooky, very spooky. So, people actually are scared, I think.
Now, here's my question, the really, really sick people that are holding out, is that gonna turn into a shit show here in 3-4 weeks?
They're probably not whole, if they're sick, that sick, they'd probably be with us, they'd probably be in the system. I think DeWine did us a great service by closing everything early. And you saw what happened to Florida and New York, and they didn't close things, and they said, go back to normal daily activities, and, you know, they're overwhelmed. So, but the question is once we open it back up, are we gonna see, a bump in arms? I think if you keep kids out of school for the rest of the year and let the summer go by, it'll probably be the best bet. As long as we maintain some social distancing for a while. But you start mass gatherings, that's just gonna.
Right.
Do you think it's been here longer than they say?
Probably had. But with that replication rate and the death rate, it seems that it got here near when it did. Because we would have, if it really was as hot as it was, and the replication rate as big as it is, it should have been more, it should have hit our radar earlier as it really was full on here. I don't know, I had something in January, I was sick and had a fever and felt like hell and got a flu test and it wasn't flu. You know, was it that? I'm waiting on the antibody test to come out, which I think we're gonna do widespread testing to make sure who's got it and who hasn't, so we can be a little more at ease. At least from my standpoint, I'd like to know, because then I can walk into a room where I can walk into somebody's house and know that I'm not gonna be sick from doing it.
Yeah, I had the same thing in January, 4 days of fever. He was negative, they could find nothing.
Yeah, I went home from work, went to bed, and it was very not like me, I was down.
It was at our house in end of December. It's like 7-8 days fever. And then started to go.
Yeah, I mean, I think a lot more of us have had it. The numbers are much bigger than it is because not everyone's getting tested. And like all the young people who aren't sick aren't really going to get tested. People freaking out about it are going to get tested, but and then the real sick people. So I think it's not necessarily a representative sample of what the population is, just because of the who's getting tested and how many tests are being run. So.
Right.
Question.
No other question? Here's your chance.
Stroke going well for everybody. Everybody feel good on that. Remember, the same diseases still occur every day.
Oh, blood volume's down.
Yeah, why that? How much?
Significantly. Say,
I don't think we've had 10 runs in the last 2 shifts.
Yeah, last week I think we only did 22 EMS rides. In a week.
we average 6 to 7 a day.
Right.
50%.
We still have a frequent flyer in Belfast.
Right, but it shows you who needs to be involved in our system. And it's the same thing in the ED. It's like, there really should be 50% of the people in my ER at all times, not 100% say.
Right.
Hopefully this will like make people realize that you don't need to go to the hospital for step 2.
That is a question. Like, we have a guy that currently is calling
Once a week.
maybe twice, up to 3 times a week, to go to the hospital. He is a pain seeker. It's the same problem every time, but foot pain. So it's extremely pain. At what point can we especially with what's going on now, saying that this is becoming a burden on our resources, and when can we refuse him with an alternate transport, whether it's Uber, taxi, call these people.
I mean, that'd be a discussion that Steve and I and legal of the county or the township would have to talk about. As long as our resources are there, I think they'll tell us to transport him. But once our resources get more scarce, I think at that point, that's where he falls into that category of refusing, from our standpoint to take him.
Well, they bumped you from Bethesda and Claremont, and now must be transported for price for paying.
Yeah, what about the hospital shopping?
No. If you're having an emergency, you can go to Bethesda. Whatever you're close, we're not driving to Children's, we're not driving, I mean, that's been my big thing forever is because if you drive him, who's with us every week, and that little old lady has an MI and she has a bad outcome, that's on us.
That's what I tell everybody, don't let them hospital shop. Bethesda or Claremont.
Yeah. Two closest facilities, you got a Mercy to choose from and a Bethesda to choose from. But it's hard to say no because in the retrospective scope, what if something really happens? Right.
He keeps on telling me that that's what off. It's like, call us when you do, I guess.
Yeah. But when it comes down to it, I mean, you assess the foot. Is it pink? Is it got good cap refill? Is it got pulses? Has it got motor strength? All those things. And you're fine. You can find a way yourself, but you're not having a life or limb threatening illness. So we've got other things that we have to do. We're sorry.
Fair enough.
Yeah. And make sure you have your full medical screening exam, and those are the ones where you have to even do more than you would normally do on a run, so that you can document that. It's all in documentation. If it's not on your piece of paper when somebody asks you the question in a month, you're likely liable. I think some of you guys are too young to remember what happened in Hamilton Township when that lady killed herself or the husband killed her in the bathtub. And they were being grilled as to where they were on the Reeves stretcher carrying her downstairs. What position were you in? Were you the first? Were you the second? Were you the back? What's that?
To be fair, their report was terrible.
Oh, well, yeah. But still, write it down. That's what I tell the residents every time I'm, teaching them something. It's like, write it down. You have to put your thinking into your report. If you didn't think it and you didn't say it, it didn't happen, and you're liable. Questions? Anything else you want me to talk about?
Yeah, covered it pretty good. I'll get that addendum for you.
Yeah, that's easy.
So there's a difference for hypoglycemic patients. There's a difference between the patient refusal and treatment release. Both of those are covered in the protocol.
Mm-hmm. It should be.
What's that?
It should be.
Would you go over the difference between the refusal and a treatment release? So everybody.
Well, but the refusal can also be part of that treat and release too. So, the refusal is just a refusal where you come in contact with the individual and they say they don't want anything, and then you ask them and you document. I asked them if I could take their blood pressure, take their heart rate, take their oxygen, listen to their lungs, do my full medical screening exam, and they said no, and here's the two witnesses. Whereas a medical refusal after treatment would be, do you full history and physical, you put all that down, you fix the patient's hypoglycemia, you write it up as a treatment, and then a refusal at the end. So it's pretty much the same, but a lot of times under refusals, obviously, you're gonna get a lot less actual physical contact with the person.
Well, it actually covers different stipulations. So like for a treatment release, you have to maintain a blood sugar over 100 for 10 minutes to be a treatment release.
Mm-hmm.
But they can refuse transport no matter what.
Right.
So we had a gentleman that His blood sugar wouldn't go up above 72 or something. Wouldn't go up. They asked him to
And
go.
I'm fine with 72.
They asked him to go to the hospital. Please go to the hospital. Please go to the hospital. He said no. Refused transport.
Right.
So
Maybe like
the
mine.
difference was it couldn't be written up as a treatment release, which it wasn't. It had to be written as a
Right.
So on the treatment release, do you still want a refusal sign?
Yes. Yes. That they are refusing, because you're expecting to take them to the hospital. We are not a service that delivers medical care at someone's house and then it goes home. You know, we're being called to transport them somewhere else. So I think it is a refusal with your treatment. Just like heroin, when you get there, you get Narcan to refusal to go with them. So, which would be my preference. Yeah, but those are the ones, and those are the stickiest ones, is the hypoglycemics and the ones we actually did something to walk away from. My easiest patient to admit is one that, or take care of is one that I admit. Because I know I'm handing it from a doc to a doc and it stays in the system. The liable ones are the ones that leave, who could be sick, who didn't want to stay. Those are the ones that keep me up at night wondering, did I do the right thing? And those are the charts that, instead of my medical decision making being this long, it's like this long. So your notes and all your things should be doubly as long in the refusals as they are in the others. So you're documenting a good mental status, you're documenting, other people around who witnessed the situation. You're covering your tale because you want to paint the picture of what you saw and what happened and why you did what you did and then why you left, and you counseled them on the risk and benefits and all these things. That's where we're going to get in trouble, is treatment release. And just a little pearl. Any of these hypoglycemics that are on oral hypoglycemics, not metformin, but the sulfonylureas, the glycerides, the glipizides, the actoses, things like that, those are really dangerous treatment release. Because you can't get blood sugar back up in a patient who's on a type 2 oral hypoglycemic with just sugar. It will come up transiently, but the way those things work is there's a channel that opens up and pulls sugar into the cell. Those poison that channel and keep that open, so you keep pulling your sugar in. You don't shut it down by giving it more sugar because it'll just suck it right into the cell. You actually have to use a medicine called octreotide or somatostat to poison that receptor, and it closes that portal and doesn't allow sugar in so you can maintain that higher sugar. So that's why these type 2s on the oral meds should be transported. If you're just an insulin hypoglycemic, that's a lot easier to deal with because that's a food thing and you just feed them. But the pills are the ones that can be dangerous. We keep those in hospital overnight. There's a reason that they're toxic on them. If they're dehydrated or they're in kidney failure and something metabolically has happened to build up that concentration of that drug in the system.
You got anything for us right now?
Haven't heard anything bad, so that tells me we're doing well. Usually him or Daryl's calling me. I know. So when they don't hear from you, that's good. If you guys have questions, especially the young guys that haven't been around me much, just shoot me an email. I'm always there. Shoot me a phone call. I know Danny's got or Kevin's got all my stuff. Just I'm morning, noon, night, never. Just want to run a run by or question about a run, or it's easy. If I can make him a good paramedic, shit.
We're so
That's
sorry.
right.
Thank you, we appreciate it.
Absolutely. Let me know what else you need.
We will.
I'm always around.